Happy Wednesday, everyone, and welcome to today's webinar, Stroke Hub and Spokes, Keeping the Wheels Turning. Before we get started, I'd like to go over a few items so you know how to participate in today's event. This webinar is being recorded and will be sent via email within 24 hours. There are no continuing educations associated with this webinar, but you may access a certificate of completion in your follow-up email at the conclusion of the event. You will have the opportunity to submit questions by typing them into the question pane of your control panel. You may send your questions in at any time during today's presentation. We will collect these and address them during panel sessions throughout today's event. If you experience any technical issues during the presentation, most can be resolved by refreshing your browser. If your issue is not resolved following the refresh, please refer to the go-to customer service team, whose contact information can be found in your webinar confirmation email. To view live closed captioning during today's presentation, please utilize the hyperlink in the chat. I'd now like to pass it to my colleague, Jeannie Luciano, our National Senior Program Manager for Get With the Guidelines Stroke in AFib. Jeannie?
Thanks, Gino. So we can go. Next slide, please. We want to welcome everybody today. Next slide. So just as a heads up, we're celebrating 20 years of Get With the Guidelines Stroke this year. So you will see things coming out over the course of the next year going into early 2024. Next slide. So I couldn't let this pass. As we kick off American Stroke Month and head into Nurses Week, I want to acknowledge our colleague Lynn Hunley, who we unfortunately lost in November due to glioblastoma. If passion was a person, it would be Lynn. I would normally ask for a moment of silence, but there was nothing silent about our friend Lynn. And to honor her and her work, really do it with actions. Mentor someone. Thank your mentor, continue to learn and care for your patients, and she would really love that. So just an acknowledgement of our colleague. Next slide. We have quite a treat for you of presenters here today. We got the true top of the line. I'm going to give you a brief introduction to each of them. So Michelle Sellers. Michelle Sellers has been the director of the Neurorescue program at Penn Medicine since April of 2013. In that capacity, she coordinates the Penn Telestroke program, ensures efficient transfers of neuroscience patients to the Penn Medicine system, and supports stroke program development across a network of 6 Penn Medicine hospitals, as well as multiple alliances outside of the system. She has been a neuroscience nurse for over 34 years. Her previous experience includes acting as a clin spec for the Department of Neurosurgery, as well as a coordinator for stroke clinical trials. She has been a stroke certified registered nurse since 2015 and has presented regionally and nationally on numerous stroke topics. Our next presenter is Kimberly Holmes. Kimberly has been a registered nurse for 20+ years and is currently the stroke program clinical nurse specialist for Bay Health in Delaware for both the Kent and Milford campuses. Kimberly has presented numerous times at the state and national level on acute stroke care and cultural sensitivity. Kim is particularly passionate about health disparities that affect women and minorities. She has been an avid volunteer for the AHA and has been elected to the position of board president of the Delaware Heart and Stroke Association for the term of 2020 to 2023. She is also an active member of the Stroke Systems of Care and Stroke Nurse Focus Group. Kimberly is the inaugural chair of the Delaware Stroke Systems Committee, which was formed under the Office of the Division of Public Health. She is very proud of the collaboration across Delaware health systems and the positive outcomes that have been achieved in the Delaware stroke system. We also hope to get Ken Reichenbach. That crazy guy's taking care of patients right now, but hopefully Ken will be able to join us. He has spent 26 years in the Lehigh Valley Health Network, working in a variety of positions from radiographer, nurse, and nurse practitioner. For the past 14 years, he has worked in the stroke program and serving as the program director for the mobile stroke program. Ken has helped to develop the teleneurology program, the mobile stroke program, and the neurointerventional radiology clinic. He has worked on the implementation of artificial intelligence for neurological imaging at Lehigh Valley. He has also worked as an advocate between Lehigh Valley and EMS agencies, providing education and outreach to the community. Additionally, from Lehigh Valley, we have Erin Conahan. Erin has been the clinical nurse specialist for the stroke program at Lehigh Valley since August of 2019. She serves as a role model, educator, and resource person to facilitate professional development of staff, improve community awareness, and incorporate evidence-based guidelines into practice. This is done through her oversight of performance improvement, community outreach, and continuing stroke education. Additionally, she oversees institutional compliance with Joint Commission disease-specific certification standards for the Stroke Center certification and coordinates certification process. She has presented regionally and nationally on various stroke topics. And then last but not least, from Lehigh Valley, we have Claire Ann Matheson. Claire Ann has been a member of the Lehigh Valley Hospital stroke team since 1999. She is recognized for over 37 years of nursing expertise in neuroscience nursing. Her experience includes emergency care, interventional care, neurocritical care, and medical surgical nursing. She provides consultative services in the area of stroke center development and ongoing maintenance of acute care services to support delivery of care. Claire Ann works with a large tertiary stroke system that supports 9 acute stroke campuses. Her experience includes overseeing clinical operations, development of ongoing performance improvement and quality efforts, and staff development. Claire Ann is actively involved in stroke care delivery both locally and nationally, volunteering for several American Stroke Association and American Association of Neuroscience Nurses Committee and Task Force. So I am at, we'll go to the next slide that will show our objectives for today. So our objectives for today are to develop an understanding of essential components of successful acute stroke management during transitions from spoke hospital to hub hospital, and identify opportunities for collaborative quality improvement in the hub and spoke hospitals. So I am happy to hand it off to our first speaker, Michelle Sellers.
Thanks so much, Jeannie. And hello to everyone who has joined the call. I'm here to speak to the hub and spoke experience from an urban academic center perspective. So as Jeannie said, I'm working at Penn Medicine currently, and our hub at Penn Medicine is the Hospital of the University of Pennsylvania, which is our CSC. In addition, we have 5 other Penn-owned stroke network hospitals, 4 of which are primary stroke centers, 1 of which is soon to be a thrombectomy capable center. 2 of those primary stroke centers, Penn Presbyterian and Pennsylvania Hospital, are located very close to us in Philadelphia. 1, Chester County Hospital, is in the Philadelphia suburbs. And then we have another center at Princeton, which is in New Jersey. The soon-to-be thrombectomy capable center is about 80 miles away in Lancaster, PA, Lancaster General. We also partner with 3 other hospital systems that are not Penn-owned, and they are all primary stroke centers. Currently, all of our partner hospitals are within transfer distance. So anybody that any patients that we evaluate at our spoke hospitals that need an advanced level of care are coming down to the hub at HUP, which is a little bit of a mouthful, but hopefully I won't make that mistake too many times during this talk. Gina, I'll go on to the next slide. I have no disclosures. So having been at this for a little while, I feel like I've seen a real switch in sort of the mindset of how hub and spoke models work. I think in the beginning, there was very much a hub-centric viewpoint where the hub dictated processes or, was the one that would say how policies and procedures would work. I feel like we've really moved in the opposite direction now, and that's for the good. We really seem to be more spoke-centric right now. We work very, very collaboratively with our spokes to improve our entire sort of stroke ecosystem, as it were. Over the years, as we've worked to develop this stroke system, we've learned a few really good keys to success. First off, humility. Listening is absolutely vital. We cannot go into a spoke partnership believing that we have all the answers. We really need to listen to the teams at our spoke hospitals. For after all, they're the experts. They know their hospitals, they know their patient population, their environments. They know their strengths and opportunities better than anybody. So it's only by first listening are we able to then determine how best we can integrate the things that an academic medical center brings to the table into the improvement of stroke care. Then we move on to teamwork. Once we've listened and learned, then we can team up with the folks at our spoke hospitals and really start to navigate the incredible complexity of providing exceptional stroke care across our network. Now, we have a lot of tools to do that, and we utilize them all, but we found that not all tools are needed at all spokes. So again, we really need to personalize the solutions that we offer to each of our spoke hospitals. Telestroke is one of our older tools, but certainly one of our most vital ones, and we still lean on that. Added to that, though, we now are able to offer options for teleneurology as well as teleneurocritical care. And these have been important tools as they've helped some of our spoke hospitals maintain some patients at the local site rather than transferring patients for monitoring. And this has been just a win-win. The spokes really would like to keep as many patients as they can. The families and patients don't want to transfer if they don't need to. They prefer to be in their community. And obviously, I think all tertiary medical centers are dealing with bed strain in this environment. So this really has helped us across the network. Another tool is our shared image interpretation software. Of course, this allows us to quickly access imaging across all of our network hospitals, allowing for rapid diagnosis and treatment decisions. One of the more exciting tools that we're still really harnessing the power of is our shared EMR. Across our Penn-owned facilities, we are all on Epic and all in the same version of Epic. So we're just beginning to develop the building blocks to help sort of streamline stroke processes across that part of our network. We're currently using a consistent shared Epic-based alerting system for all ED stroke alerts. So regardless of what ED our patients go into on our Penn-owned facilities, we're able to use the same HiQ alerting platform. What that allows us is improved data collection at each of our sites because it goes through Epic, so we're able to pull a report on all of our alerts. But it's also one of the building blocks to streamlining alerting directly to the team at the Comprehensive Stroke Center. This week, we also launched an Epic-based secure chat function, which allows currently for faster communication among the teams as we move patients either from our ER or from another hospital into our thrombectomy suite. My vision is a network where a spoke hospital will be able to place the stroke alert order when that patient hits the ED, that will launch an alert to the phones of the team at the CSC. From that alert on their phone, they'll be able to access the patient record, review images, and begin a secure chat with the treating team over at the ED. In that chat, they could determine if a telestroke is needed. If so, we could just go ahead and beam into the cart and begin that telestroke consultation. In my dream world, that would also alert, if we decide to transfer, it would also alert our transfer center and our PennStar team who does the transfer. Now, we're nowhere near that yet, but we, as I said, are laying the foundation and are really hopeful that this is going to help us streamline and hasten the care of our patients. I'll also add that the Epic-based alerting HiQ that we're currently using was actually piloted at one of our primary stroke centers at Princeton. So again, just another example that not all the knowledge and innovation flows direct from the hub exclusively. We're really working in a collaborative manner to improve care. Lastly, but most importantly, communication. I've already alluded to the importance of communication for individual patient care in the secure chat and moving patients into the IR suite, for example. But it's also vital for the hub to then communicate back how that patient does if they end up being transferred and sort of close that loop. While the patient-centered communication is obviously vital, I think we also need to think about sort of the bigger picture and the communication of our data across the network. In my role, I pretty much record and track, well, almost everything we do. Calls, times of calls, how long we're on calls. Do we recommend treatment? Do we recommend transfer? So I'm constantly collecting data that is helpful in quality improvement work. Across our network, obviously, all of our stroke centers are collecting data to meet their metrics, whether that's door in, door out at our primary stroke centers, door to groin at our comprehensive and thrombectomy centers. And we all play a part in improving each other's metrics. So I think it's really important that we share that communication, are transparent, and really work together to elevate all of our practice. So one size doesn't fit all. Solutions must be curated and in keeping in mind the strengths and benefits of all of our spokes. I wanted to just talk through one of the curated solutions that we came up with that was specific for our downtown spokes. It may be counterintuitive, but our two closest spokes were the spokes that we have the most trouble getting transferred to us. That's due to traffic, but also candidly, it's due to lack of ground resources for moving patients from our center city primary sites to our hub hospital. So we put our heads together and came up with an expedited thrombectomy transfer process, which you see pictured here. What the purpose of this was to really work in parallel rather than in series. So the plan is when a patient hits one of our PSCs downtown, if they come in with gaze preference or aphasia, hemiparesis, and they're within a 24-hour window, we're really asking them to call us on triage. Let us know so we can start identifying and moving assets. Even if we end up canceling that transfer because the CT scan shows a bleed, for example, we're at least on our way. And so when we make that decision, our resources are there at the bedside. And just as we can go to the next slide. As a quick little case study showing how this process can work, this is a patient that presented to our emergency room at Penn Presbyterian. They came in around 6:40 in the morning with left-sided hemiparesis and facial droop, which initiated the call, caused them to initiate the call for an expedited transfer. They called us from the triage, so within 5 minutes, they were letting us know that they had a patient they anticipated transfer. We began to identify resources for transport. And yes, even though Penn Presbyterian is less than 1.5 miles from our hospital at the University of Pennsylvania, we did identify that we needed to airlift this patient because we did not have ground assets. So we started moving the helicopter even while they were in the CT scanner. CT was completed about 20 minutes after arrival, and then the patient was taken right up to the helipad for transfer. The door in, door out for this patient was around 30 minutes, which I know, we're all struggling to get below 60 or below 90, but this just shows when we're working in parallel what kind of incredible numbers we can get. Patient was in the OR less than 60 minutes from when they arrived at Presbyterian Hospital. So, I mean, that's just phenomenal. And we were able to go on to achieve a successful TICI-3 revascularization. And if you can go on to the next slide. And this is just an example of some of that feedback that we then like to provide back to our primary centers who transfer to us. So this just gives the highlights and is something that can then be shared, because this is really a success of partnership, of working together to identify pathways and processes that work. And because of that partnership, we were able to send this gentleman home 3 days later without deficit. That only happens with us talking to each other, sharing with each other, collaborating with each other, and really treating it as a collaborative network. And I will end there.
Thanks, Michelle. So we're going to have a short panel discussion about any questions. I'm going to start this off by saying there's some, you got a lot of questions in the chat here. Do you have a monthly standing meeting or cadence for sharing feedback on the transfer patient's outcomes? And I'm going to also bring in our other presenters, and Kim is on here but does not have video, so Kim and Claire Ann and Erin can also chime in. But the first question from the group is, do you have a monthly standing meeting or cadence of sharing feedback on transfer patients' outcomes?
Yeah, so I actually send out our transfer our data on all our telestrokes and our transfers to our partner hospitals on a monthly basis, which includes what happened to them, what their length of stay was, what their disposition was after they left the hospital. And then as for standing meetings, we do have standing meetings with each of our partner hospitals on a monthly cadence.
Any questions or comments from Claire Ann and Erin or Kim?
I can add, we do a similar process where we have a monthly telestroke partner meeting. So this is with all of our sites all together at once, and then quarterly we kind of have a little bit of an expanded system meeting with some expanded leadership that are included.
We have an additional question asking about what shared tool do you use for imaging?
We're a rapid AI shop.
Okay.
At Lehigh, we're a Viz AI shop, so that's another form of AI that is also frequently used.
Okay. We'll give you one more question here. How is Epic used to make a stroke alert? Is there a button? It's an easy.
That's a good
There's
one.
not an easy button yet, and boy, do we wish there were. So what we've developed is we utilize the HiQ Stroke Alert, which is the HiQ. HiQ is the Epic application that delivers emergent messages. When the patient hits one of our ERs, the HiQ alert is embedded in the order. Is embedded in the order set for the stroke alert patients at each of our EDs. So they don't even have to think about it. They just place the order set. We placed it in the same order that you get the CTs with purposely because they're always going to order the CTs. So we embedded it with that order set so that it just automatically goes out. Some of our sites are using it purely for data collection. Some of our sites, like our hub hospital at HUP, uses it to respond to the alerts.
One more question here. What is the assessment tool you use to identify ideal candidates for transfer?
That is, I guess it's on a case-by-case basis. I mean, we use the NIH stroke scale when we're discussing the cases with our outside hospitals. And really, the decision comes down to the stroke scale or the need for thrombectomy or higher level care.
Perfect. We have additional questions that we will try to answer offline, but we are going to move on to our next speaker, which is the esteemed Erin Conahan.
All right, so as Jeannie had mentioned earlier, I'm going to be pinch hitting for Ken, who is serving as an NP in our neuro IR clinic today. So I have the pleasure of doing a mobile stroke story. So this is at a Rite Aid and it's I've fallen. So next slide, please. Ken and I have no disclosures. And just to kind of set the stage, so with our mobile stroke unit, where we are in Pennsylvania, there are two ways that we can be dispatched. The first is through our Lehigh County EMS system, so they can dispatch us directly, Or we have relationships with some EMS agencies that if their truck gets on scene, they determine it's a stroke, they can call for us. So in the case that we're going to review here, this was a call that initially went out to one of our local agencies. It was an ALS fall victim. So a lot of information you get when you're going out on these calls, right? So the responding team gets on scene, and they very quickly realized that this 83-year-old who fell while she was shopping, didn't trip over anything, was not answering questions, not following commands, and definitely looked like a stroke. So they called and requested our mobile stroke unit. So our mobile stroke unit, we were dispatched at 13:27, sorry, and then if we go to the next slide, please. Our arrival time is 13:39. So while they're waiting for our MSU to arrive, the local EMS agency is getting blood sugars, getting vital signs, pretty much packaging the patient. That way, when our team gets on site, all we do is move from one stretcher to the next and start to load that patient for CT. So on-scene arrival time is 13:39. We quickly got a RACE score, and RACE score is a severity scale that is embedded in the EMS protocol in Pennsylvania. So once we got that RACE score, get the patient loaded for CT, and while the crew is loading the patient into position to get those images, our PHRN is speaking with the crew that initially responded, getting the story, talking to her friend who was with her while she was shopping, and then also notifying our telestroke doc, like, hey, by the way, we're actually ready to go. So if we go to the next slide. Her images were started at 13:48, so it does take a little bit of positioning in an 83-year-old, a little kyphosis. You have to make sure that they're nice and straight on that table, just like you do on a regular CT machine. So we were quickly able to get those results to our neurologist to review them at 13:50, saw no hemorrhage, and at this point, he goes ahead and starts the teleneurology consult. Next slide, please. So telestroke consult begins at 13:50. Her last known well is 13:10. So we're talking 40 minutes from when she had the start of her symptoms. She has no known allergies. She has a pretty significant cardiac history. She does not take any antiplatelets or anticoagulation. And we do weigh our patients on the MSU, and she did come in at a 48-kilogram weight. 13:52, her NIH stroke scale is completed by our stroke neurologist, and he gets a 20. And at 13:58, with the information we have at this time, we determine that she's a candidate for Alteplase. So we use Alteplase in our hospital system. Now, being the patient is aphasic, and it's a friend that's with the patient, our neurologist did reach out to the family and review the plan of care and kind of what we're doing just to make sure they were okay. So at 14:08, Alteplase is administered. So I'm just going to pause there for a second. So last known well is 13:10. 58 minutes later from the onset of her symptoms, she gets drug. So it's kind of pretty amazing, right? It's modern medicine. So we'll go ahead to the next slide. Because she had the RACE score of 8, which signifies she's at high risk for having a large vessel occlusion, they did take her to our CSC. So arrival at the CSC is 14:21. On arrival, she had no change in her neuro exam. We got the CT angiogram at 14:26, and the official imaging read is at 14:48. So like many of you, I imagine your team is in CAT scan as it's being done and reading it. This is, the official read documented in the record. Decision to treat, to take her to the table, is at 14:59. So again, even though we had contacted the family to get TPA, kind of started the conversation that she might need further treatment. At our site, our neurointerventionalists do have a conversation with the family as well. So family agreed to go ahead with procedure. Arterial puncture is at 15:20, and at 15:48, she's recanalized. So again, just kind of thinking, 13:10 is her onset of symptoms. A little more than 2.5 hours after the symptom onset, she has TICI-2B recanalization. So if we go to the next slide. So her outcome, radiologically, she had a good outcome. Post-procedure, she wasn't doing very much initially. 24 hours post-procedure, we got routine imaging like everybody does. There's no hemorrhage, no like unexpected image findings. But as the day went on, she did require additional pressors for blood pressure support. And kind of I alluded to earlier how sick her heart was. She did, despite aggressive intervention, she did go into cardiogenic shock. There were conversations, multiple conversations with the family, and they agreed at this point to transition to care, comfort measures. So just kind of bringing home the point that all of the data shows us that the earlier we get patients treated, whether that be with thrombolytic or with going to the interventional suite and pulling that clot out, patients tend to have good outcomes, with better outcomes. But despite getting there 2.5 hours from symptom onset, getting good radiographical results, unfortunately, her clinical path did not follow. So we'll go ahead and do the next slide. There are always questions about the MSU and really what does the MSU do? So just spend a couple minutes talking about this, not even a couple minutes. So the MSU is bringing the neurological emergency room to the location of the patient. So we're bringing you the CAT scan, we're bringing you the specialized staff. We have our stroke neurologist via camera and tele-equipment to be able to actually, it's a 4-to-1 ratio who's caring to this patient. And the results of many of the trials that are coming out are showing that when we look at the use of mobile stroke units, we're increasing the amount of patients who are able to get thrombolytic. We're able to get that to that patient faster. And most patients do have a good outcome. I think the bigger question with our MSUs is not going to be, do they affect treatment? It's going to be where's the best place to put them to affect the most people. So if we go to the next slide, people always ask about our experience. So we are not a pure mobile stroke unit. So because we're partnered with an area agency, if they run out of trucks, our team goes out on medical calls. So that's why you see the 2 lines on the left. So the top line are the stroke calls that they've done, and the blue line are the medical calls that they've done. And the team is expected to perform according to standard practice for any medical emergency. And then on the right-hand side of the screen, you can see our interventions to date. Again, we use Alteplase in our network, and then the number of patients that we're able to go to the table. So I believe that kind of wraps up the MSU story.
Okay, great. Thanks, Erin. Let's bring our team up for panel discussion. So I'm going to get you started off. I'd like to know who staffs the mobile stroke unit.
Okay, so our mobile stroke unit is staffed by a PHRN and a CT tech that are from our hospital. And then we also have an EMT and a paramedic that is supplied by the agency we partner with.
Perfect. Michelle or Kim, any questions for Erin? Michelle, you're muted.
I can't read lips that well, Michelle.
We can hear you now. Nope.
Okay, now am I unmuted? Okay, sorry about that. So Erin, yeah, I think we always have questions for those of us who don't utilize MSUs. What are the capabilities of the CT scanner?
So our CT scanner, we have a Ceratom on the unit, and it's an 8-slice scanner. So some centers have the ability to, in addition to getting the non-con CT, they do get a CTA right away. Our neurointerventionalists really like having the ability to see the aortic arch, the great vessels in the neck, to be able to plan their journey. With our Ceratom, I don't know if you've ever seen one. The hole is extremely small, and we have a larger population in the Lehigh Valley. So many of our patients, you can't get much below their chin into the actual unit. So to get all those vessels is really a struggle.
Thank you.
Any questions, Kim? I know we can't see you, but I know you're there.
No, I'm good. Thank you, Jeannie.
Okay. Aaron, there's a question here. Can you treat hemorrhagic stroke on the mobile stroke unit? Do you ever reverse or anything on the stroke unit?
Yeah, so we do, because we can get that CT, we can see if that patient's having an ICH. So we do have Kcentra on the truck, so we are able to reverse any coagulopathy. We do have a point of care machine for INR if the patient would be on warfarin, and then also aggressive blood pressure control. So we have additional medications on our mobile stroke unit that go outside of your traditional ALS protocol in the state of Pennsylvania. So we have nicardipine, and labetalol, so we're able to affect that blood pressure treatment early on. And then if the patient would have a seizure, we also have Keppra on board, so we're able to manage that special moment as well.
And just one more question. Who makes the ultimate treatment decision for either the ischemic or the hemorrhagic patients? Who's calling the?
Yes. So we have, we have a PHRN, and we also have one of our PHRNs is also a stroke NP. So we all, as we're working, kind of get that feeling, are we going to treat or not treat? But ultimately, it is a stroke neurologist who is dialing in via camera to be able to make that decision.
Perfect. Thank you so much. We really appreciate your presentation. And I think we're going to move on to Kim.
All
There we
right,
go.
thank you.
Kim, can you, are you unmuted?
Yes. Hello, everyone. I will be presenting on my medical center, Bay Health. We are located in Delaware, central and southern Delaware to be exact, and we are the second largest healthcare system. I have no disclosures. We have two main campuses. We have the Kent campus and the Sussex campus, and we have a freestanding emergency department in Smyrna. We are a not-for-profit healthcare system with more than 4,000 employees and a medical staff of more than 400 physicians. We are an affiliate of Penn Medicine in regards to heart and vascular care, cancer, orthopedics, and neurosciences. We were quite busy, as was everyone else, in the last year with over 100,000 emergency department visits, 17,000 patients admitted to beds, and millions of dollars in unreimbursed care to our patients. Next slide, Gino. So what I wanted to do is just kind of give you a glimpse of acute ischemic stroke and the number of patients that we do serve at Bay Health. And this is all within the calendar year of 2022. So we are a spoke hospital center, and we cared for a combined total between our three campuses of 382 patients with a diagnosis of ischemic stroke, of which 77 had a large vessel occlusion, which required transfer to a comprehensive stroke center. So here in Delaware, we only have one comprehensive stroke center, and that is Christiana Care, which would be considered our hub, of course, and that is located in northern Delaware, specifically in Newark, Delaware. We also are very lucky to have the Delaware Stroke System of Care Committee, and that is formed under the Delaware Division of Public Health. And we have been in existence since 2017, of which I have been the inaugural chair, which Jeannie spoke of a little earlier, just able to actually pass that on just this year, so 6 years kind of overseeing that, and it's been just eye-opening and just a great sense of pride. We really try to keep our patients in state so that they can be closer to home, of course, and receiving that time-sensitive care just obviously as quick as possible. All of our hospital systems are designated stroke centers. all being primary except for, as I stated, our one comprehensive center, which is within Christiana Care. Next slide, please. Okay, so I am going to present a Tenecteplase case, and we actually went live with Tenecteplase here at Bay Health in late October of 2022, and we were first in the state as a healthcare system. And so this patient was actually in January, so this was one of our best cases. So of course I wanted to share that one just a couple months ago. So just a little bit of back history. It was a 70-year-old plus male, past medical history, hyperlipidemia, hypertension, and ischemic cardiomyopathy. The patient was on Plavix and aspirin, and he was doing just fine until 15 minutes prior to arrival. His symptoms did include a right-sided weakness and aphasia. His family member did call 911, so we are happy about that. And EMS recorded him VAN positive in regards to aphasia and neglect. So this patient did present, to our Sussex campus at 9:12 in the morning, and this just happened to be a weekday. The stroke alert was activated at 9:15. This patient had an NIH of 19 at 9:26. His blood pressure was fine to proceed with a thrombolytic. It was 174/84. We had a blood glucose of 125. Our neurologist was notified at 9:16. We were able to obtain a CT as CTA shortly thereafter, which did show a left internal carotid artery occlusion. With this case, I do want to kind of highlight the fact that we used telestroke. And at Bay Health, we normally have one stroke on-call neurologist. And so that neurologist happened to be at the opposite campus that day. He was at the Kent campus. So he did request that telestroke be used. And we have utilized telestroke for quite some time now. It seems as if we're always kind of tweaking the usage of it. Just in last October, we use the Amwell system for telestroke, but what we kind of were able to identify was that with that new system, we were only using it from 5 p.m. to 7 a.m. when our neurologists were not, on site. And what was happening with nursing, and we all know with the number of travel nurses and just staffing, just in general, we were just finding that it was always kind of, someone was forgetting a step and then having a hard time logging in and things of that nature. And so what we decided to do just this last October was to have the cart always brought to the bedside, no matter what time of day of the week, regardless. If just for nursing to kind of get in the habit of getting it to the bedside and getting it, hooked up so that if the neurologist requested it, we would be saving time. So indeed, no delay with this case. Our Comprehensive Stroke Center, Christiana, was called at 9:37. And that is a metric that we collect here in Delaware, and you will see that in the next slides. We were able to administer Tenecteplase at 9:46 with a blood pressure of 182/83, since the patient did have that large vessel occlusion. And the other thing that I would kind of, like to put in this area, one thing with calling our Comprehensive Stroke Center, we do have Rapid AI, and actually all of our stroke centers within Delaware have Rapid AI for imaging. So that makes it obviously really, good for sharing that imaging in the shortest amount of time possible, so a decision can be made upon transfer approval. Also, what we have when we have the sense that we are going to transfer a patient is what is known as an easy button located in our EDs. And this easy button is actually for LifeNet, which is our flight system here in Delaware with Christiana. And we have been empowered to use that easy button, and it just happens to be red. So sometimes someone will say the red button or the easy button. We all know what that means in our ED, but we have been empowered by Christiana LifeNet to hit that button as soon as we believe we have someone who may be transferred. You know, we have found that it definitely saves time to kind of start that checklist for them to be able to, you know, dispatch. And if we decide in that 10, 15 minutes that the patient truly isn't a candidate for transport, it's no big deal to call them and cancel. And they have assured us that, you know, they would rather us hit the button as soon as possible, and if needed, call them to cancel. You know, it's more of the sense and the urgency to kind of get the ball rolling as far as that helicopter, you know, of course, being dispatched. This patient was actually discharged at 10:15 that morning. Our door to needle was 32 minutes, so we did meet our goal of 45 minutes. And our door in, door out is 63 minutes. So we are really proud of that, with the goal being 90 minutes. Here in Delaware, we have established an internal goal for the state of 90 minutes. And so we are getting better and better at that door in, door out. I've had quite a few under 90 minutes. You know, I will say during the pandemic, you know, our door in, door out were well over 120 minutes. So to see 63 minutes, we are all just amazed at the great teamwork between both healthcare systems. This patient was transferred, as stated, to our comprehensive stroke center, Christiana Care. Next slide. And this is the feedback report that Christiana gives all of the primary stroke centers in Delaware, which is so very much appreciated. As you can see, there is every bit of information. It's very thorough in the sense that it actually starts with the spokes information in regards to arrival time, last known well, and NIH, and all of that care that actually occurred at that spoke hospital. And then, of course, they move into their care as the hub with arrival. So I'm going to continue on with the arrival portion of care. So this patient did arrive at Christiana Hospital at 10:55, and upon arrival there, the NIH was actually 22. Their repeat non-contrast head CT showed no bleed, and that patient immediately went to the interventional suite. The thrombectomy was performed with an initial TICI grade of 0 and a final TICI grade of 3. We also are very proud to have our physicians listed on these reports. It just gives a sense of ownership for both hospital systems to be able to, you know, discuss the care and to just see the teamwork that is existing between our neurologist, our neurointerventional radiologist, and our stroke neurologist, of course. A little bit below in the slide, you can actually see the metrics that are provided between both hospital systems. So we look at our ED arrival to access center, transfer out, call time. Our goal, our target is 30 minutes, and we reached that in 26 minutes. And our door to transfer to other hospital, as I stated before, our goal is 90 minutes. We were able to do that in 63 minutes. The transfer center call to the Christiana Care arrival time. That we are trending here in Delaware. We are, of course, always viewing this as an area of improvement and opportunity. And in this case, this was at 77 minutes. So as I said, as a stroke system of care, this is always, a point of discussion on how we can just tighten that time frame up to achieve, tighter numbers. The next metric that you see is the transport team bedside arrival to leaving the bedside. And that was a Delaware metric that started years ago. All of the stroke coordinators, we were talking, we meet quarterly, and just kind of decided, hey, how can we kind of get these door in, door out times, better? One was to really kind of take a look at how long the transport team is at the bedside. And as I said, I think this has been in place at least 8 years. And what we found was that one thing that was kind of slowing the transport team was our IV tubing was not compatible for them to be able to take the patient on out to place and continue on to leave, for transport. And so Christiana was able to find tubing that was compatible with what the spoke hospitals had, so that they could just kind of grab the patient and go and not have to worry about the compatibility to the pumps. So that has definitely helped us. In this case, it was 13 minutes. I've seen that done a lot quicker, but once again, this is definitely meeting our metric of 20 minutes. And then, of course, Christiana's arrival to site puncture time was well under the target of 60 minutes. So great care. This patient, the best part of this story, so our numbers look good, great collaboration with so many team players, EMS, comprehensive, primary stroke centers. But the best news is that this gentleman was discharged to home in under a week with an NIH of 0. So great work for all. And I am finished.
Thank you so much, Kim.
Oh. One last slide, just to kind of give that visual of care, excuse me. As you can see, he had an occluded cervical ICA, and then post-procedure, of course, flow was restored with that cerebral perfusion circled in green. So great work by our partners at Christiana Care.
Great. And I'm going to apologize to everyone. We might go over a little bit, which we're allowed to do. So I hope everyone can hang with us. Kim, you answered most of the questions that are coming in. I have one question for you. What video technology do you use for your telehealth assessments? Their facility uses Zoom, but they're curious to see if there's something better.
Yes, so we are using Amwell. And I will say this, our hiccup was we bought the program and used our own carts. Don't do that. Buy the Amwell carts, because our IT thought that they could kind of, we laugh about it all. It's not really funny, but our IT thought that we could rig our carts, and it didn't work. And we did that for maybe a year, and we had so many problems with connectivity, and we were meeting with Amwell weekly. So I would suggest, Amwell as a company has been very responsive, but I would truly suggest buying the specific cart that the company offers.
Great information. We'll take some more questions at the end, but we are going to move on to our next discussion, which is Claire Ann Matheson speaking about a intracranial hemorrhage case.
Okay.
All right, thank you. So I work with Erin and Ken at Lehigh Valley Health Network, and we are a hospital system in Eastern PA. So our hospital is composed of our CSC, which is our main campus at our Cedar Crest site, And then we have 4 PSC hospital spoke sites, as well as 3 newly built hospitals that are in the process of preparing for acute stroke ready status. So our hospitals are as close as a few miles down the road to as far, our Dixon City campus being the furthest, which is about 75 miles from main campus. Next slide. So I have the pleasure of being the closing speaker, and we wanted to put a little emphasis on hemorrhagic stroke transfers, which is our, trauma equivalent where we're going to stop the bleed. Next slide. I have no disclosures. So a couple of stories. So typically when we see our hemorrhagic stroke patient presentations, typically we see one of 2 presentations. So this first case is a 73-year-old patient. She is one of those, church events where they go syncopal at church and have a positive loss of consciousness, come in to the hospital, not really clear what her differential is, not called as a code stroke. And you can see door in is at 1800. As they wind their way down the differential, they get that CAT scan. That CAT scan pops positive for hemorrhage. And we're looking at a coordination of care and a door out at 2030. So think about that scenario, not quite called as a code stroke, but comes in about 150 minutes, door in, door out. And most of you would be saying like, wow, we've got to get that faster. And how do we manage that? Our next slide. Another patient scenario, 52-year-old gentleman comes in. He has past medical history of high blood pressure, some tobacco use, some alcohol. He presents by EMS with right-sided weakness, face, arm, leg, some speech difficulty. They have a last known well of 3 p.m. Elevated blood pressure, he's going right down the stroke alert workup phase, goes to CAT scan very quickly. CAT scan pops positive for left temporal lobe acute hematoma. And you can see coordination of care in that stroke alert story arm goes relatively fast. Same, key components that we'll talk about that are paramount to our management of the hemorrhagic stroke patient, but you can see door in, door out, 47 minutes. So when that hemorrhagic patient comes in as a code stroke or stroke alert, whatever you call it in your region, you can see that care somewhat lines up a little bit quicker. Next slide, Gino. So our ICH care. So recently those guidelines were just re-released. You know that there's an emphasis on getting early blood pressure control, targeting that blood pressure to a little bit above 130 and really looking at doing that within the first hour of that patient arriving so that we can, again, prevent that hematoma expansion. Additionally, we're going to be conscious of those patients that are on anticoagulation and get that reversal process started quickly. As Michelle lead it in with communication, if we're going to be transferring that patient, we want to be sure that we are connecting and arranging that transfer plan. So in our system for our hemorrhagic stroke patients, those patients typically come in on our neurocritical care team service and have consultations with our neurosurgery team. And then again, while we're waiting for transfer, you'll hear me talk a little bit about what do we do with those patients while we're waiting to move those patients and coordinate care to the ICU level. So next slide. So one of the areas that we are challenged with is that ED phase of care. So after you get that CAT scan that is positive and you're waiting for that coordinated transfer, we want to make sure that we have standard work for the care and standard work for how you're going to connect with the logistic planning that you need for those patients. For that bedside nurse, it's so important to have clear communication while they're waiting for that transfer. And honestly, as we've gone through 2 stroke surveys in the last year, this has been an area that's been on the radar for our friendly visitors from the Joint Commission. What do you do with those patients? Who's managing those patients? And how are you measuring if you're meeting those needs while you're waiting for that patient movement to happen? Whether it's the patient going internally in your hospital to the next level, to the ICU, or whether they're being moved out of your hospital to a higher level of care. Next slide. So again, this is a very, very busy slide, so I apologize. I'm going to walk you through how important it is to sort of keep an eye on how you're doing with this. So as we all know, door in, door out is a core measure that our PSCs and acute stroke ready hospitals have to manage. But as Michelle pointed out very early on, this is a partnership. So the hub and the spokes need to work together and have an eye on, are we moving those patients less than 120 minutes? If it's by the American Heart Guidelines, we want that even closer to that 90 minutes. What does that look like? And if you're using Get With The Guidelines, there are some ways you can benchmark. So for us, we like to keep an eye on all PA hospitals and what's it looking like when we're moving patients on the PA hospital front. And then all stroke certified hospitals, what does that benchmark look like? And then how do we sort of compare and break that down? So you can see the upper left-hand corner is kind of our system scoreboard. The far right is an example of one of our sites boards that they would review at their operation meeting. And then at the bottom, we're using some of that advanced reporting in the Get With The Guidelines to sort of run that report and see how close are we to getting to under 90 minutes in those patients that need to go for a time critical therapy. In summary, over on the right-hand side, some of the things we've worked on. You know, how do we communicate early to our transfer center? We have a centralized transfer center, and we are blessed to have 4 helicopters and a critical care transport, in addition to our mobile stroke truck that's able to move our patients. We're using AI to leverage team communication. So all of our sites, our stroke team that is providing the coverage either in person or using telestroke is hooked up with the Viz AI imaging, as well as our neurointerventional team and our neuroradiologists, so we can communicate through that. We've really narrowed down focusing on expediting our mechanical eligible patients and our hemorrhagic patients that are moving to an ICU level. We debrief on extended transports for learning. So every month, Erin goes to our Medevac QI meeting and she walks through these cases. Our system stroke coordinators are encouraged to connect with our transport team to sort of lean into what may have happened at the time of an elongated extrication. Also, like our colleagues in Delaware using the Easy button, we are trialing that at one of our northern campuses. And then looking at priority transport criteria and how do we leverage communication. Additionally, we've added tracking the use of order sets and the documentation of vital signs and neurochecks. Next slide, Gino. All right, so transfers need a logistical plan. In Eastern PA, we have some mountainous terrain, so weather is sometimes an issue. We need to, again, make sure that we, when possible, can auto-deploy. We want to use the fastest mode of transportation. And then we want to really kind of communicate that ETA to our CSC team so that they can be ready to accept that patient. Next slide. So plan A and plan B. So we are really blessed to have some really forward-thinking leadership in our transport team, and they've worked on kind of creating some interesting relationships. So, you know, if the weather's good and the aircraft accepts the patient and flying is the fastest mode of transportation, that links up and that patient is transported and brought to the CSC site. Now, if the weather is not so good, we have worked on developing relationships with local EMS services to pick up our flight crew because they are geographically at 4 different bases, and then moving those flight crew to sort of upsize that ALS ambulance and make it a critical care transport. And this has allowed us to save some time. You know, rather than sending from our central location out to our spoke sites, we're able to sort of move a EMS asset that's a little bit closer. Next slide. So just in closing, door in, door out, you know, kind of keeping those hubs and spokes wheels moving, we've found that, you know, we really have to take a hard look. You know, what happens when that door in, door out is greater than 120 minutes? Are you reviewing those charts? Are we sending transfer feedback to leadership? Do we sort of have an understanding of why that was held up? What does the care look like when that transfer is delayed? So while they're in the ED, do we have order sets that are placed so that vitals and neuro assessments are being carried out? And not only are the order sets placed, but are we actually completing that monitoring? As most places, our EDs are really busy, overcrowded, kind of chaotic. So we want to make sure we're highlighting the specific special needs of these patients. And then making sure there's ownership of who's directing the care of these patients while we're awaiting transfer in the emergency department. You know, who's the captain of that ship? You know, so the accepting physician may give recommendations, but how do those recommendations get translated into the chart so that the team kind of knows what they're doing? Next slide, Gino. All right, so some key takeaways: right care at the right time, transfer to the right level of care fast. Often for our hemorrhagic stroke patients, we're going to require critical care transport team. Not always is it easy to coordinate and arrange movement of patients, so this really takes, you know, a dedicated team and a lot of debriefings. I really liked what, as Michelle started this off, and she talked about how each site is slightly different, so you have to curate a plan that really is tailored to the individual needs of each of the spokes. Most EDs are not set up to hold neuro patients for an extended time, so anything we can do to make sure that the needs of these patients are clearly spelled out so that we're ready to go. And then, you know, our hemorrhagic stroke population, and I know Jeannie and Gino will appreciate this, you know, this is an area that we're starting to see much more of a focus on. You know, what does the quality of care look like for these patients, and are there additional things that we should be measuring and looking at for these patients? Next slide. All right.
Thank you. If we could bring our panel up here, we have a few questions, and since we're already over time, I'm going to use this time to take the questions. So you'll see on your handout there are some handouts with information about Stroke Month, American Stroke Month tools that are available for your download. So please take advantage of them and take advantage of future webinars. So I have this question I have to ask, and it might be more of the time than we need, but what's the easy button?
So an easy button is sort of like a direct link to your transfer center. So you push that button and you're, you know, kind of immediately connected so that you can communicate that you have a time-sensitive patient that you need to transport out. You know, as Kim mentioned in her setting, it's a red button, so you're hitting that hot button to sort of go directly to, you know, get that asset online, ready to come get your patient.
There's a question. Do you guys and Ken, thank you for joining us. We appreciate that you were taking care of patients. But
I apologize.
Right? No, we appreciate it.
I'm sure my friends did a wonderful job for me.
They did. So there's questions. Do you give feedback on all your transferred patients or just patients that get procedures when they get to you?
I can say I provide feedback for everybody.
Yes, I receive feedback on all of our patients when they have undergone intervention. That 2-slide report that I did share with you, that may take a couple weeks because it's a lot of work into that, but usually within 24 hours, unless it's the weekend, I have feedback from my comprehensive stroke center, Christiana, as to you know, the care provided.
And this can go across the board here. Does your when your patients come into a CSC, do they go direct to neurointerventional?
So
Yeah. Go ahead, Clarion.
yeah, so I think, you know, that's a good question. It really depends on the time of day. If it's after hours, a lot of times our patients will touch down in the emergency department because we want to make sure everything's set up and ready to receive those patients in. And it depends how quickly we're able to get those patients. If our patients have to go for additional imaging, then they will touch down in the ER and go for the additional imaging and then come over to IR.
In our case, we have worked out a process where we are meeting, the stroke team is meeting the patient at the point of entry, whether that's the helipad if it's a flight, or whether that's at the ED door if it's ground. They're making the assessment while en route to the OR, where our IR suites now are. And if they can stop in the ED and get imaging if they think there is a need for that. Although we are now moving towards getting imaging on the OR table prior to the procedure if we feel like we need re-imaging is necessary. Usually there's cases that have had thrombolytic on board.
This question's for Kim, and the other people can chime in as well. But Kim, do you find hesitancy with your staff with using telemedicine? Did they initially find it to be an additional delay, or were they amenable to it?
So I think it's probably about 50-50. I think everyone understands the use of it, the fact that it saves time. But of course, it stays plugged up in one area. And our alerts actually go into one specific area in the ED. And so, just having to run out and go get the cart, bring it in the room, yeah, I would definitely hear quite a bit about that. But, I think more so, to be very honest, it was just difficulty with the whole IT connection of it. So, working with your IT department and whatever company you may go with for your telestroke system, or even, your hub hospital may provide your telehealth equipment. I think that is really the part that staff and even as a coordinator, I think that is the most crucial part to the success of it, is just guaranteeing that it will connect and connect quickly every time. Because what we did see when we were having difficulties with connection, what happened is our docs would just, kind of pull out FaceTime. And we had to run with it in that moment. So, that's what I would, kind of offer, is just making sure that IT is on board and there's clear communication and real-time communication. So, your neurologists who are involved can't wait until the next day to tell somebody they had a problem. They kind of need to speak on it, because at least here, our IT will come out immediately, because you have no idea when the next stroke alert is coming, right? So, yeah.
Ken is our IT, so they call him round the clock. It's not uncommon for a 3 o'clock friendly phone call from a neurologist.
Wow.
So I think we've answered a lot of the questions. Ken, I'm going to have to say that there's a ton of questions around MSU and even people requesting a tour. So we may have to have you back for an encore visit. But I would like to thank, on behalf of the American Heart Association, thank our speakers, Michelle, Kimberly, Ken, Aaron, and Claire Ann, for really your continued dedication to stroke care and to the American Heart Association. I want to thank everyone for attending, especially your several hundred people who hung with us after the hour. Whatever your role is in the systems of care, whether you're a stroke coordinator, a researcher, data, direct care nurse, you all really contribute to the optimization of these patients' outcomes. Once you leave today's webinar, you'll receive an email with a short survey, and we would appreciate if you would complete that and provide your feedback. You will also receive a follow-up email in 24 to 48 hours with a link to view a recording of today's webinar. So on behalf of the American Heart Association and our presenters, thank you for joining us today. I don't want to say happy Stroke Month, because there's not much happy about stroke, but thank you for your dedication to the stroke patients. And so we will honor you in Stroke Month and the upcoming Nurses Week. So thank you and have a good day.
Thank you all.
Thank you all.
Bye.